Thank you so much, and thank you for the kind introduction. It's a great honor and pleasure to be here today and discuss this important issue. What can we do to prevent dementia and Alzheimer's disease? Here are first my disclosures linked to some drug trials and then my grant support for our academic studies, and this is the focus of my talk today. So what I will do in my presentation, I will first briefly summarize what we know from the observational studies concerning dementia and Alzheimer's disease and prevention. And then I will move from observation to action and describe this finger trial that Harvard mentioned and some new, very fresh findings from there. And finally, I will discuss a little bit the future directions, and here especially highlighting the need of multinational studies and pragmatic prevention programs. I first want to link a little bit back for the previous presentation where Sue very nicely presented what huge challenge dementia is today. The numbers we have already discussed, so I don't go through them anymore, but it's just very clear that dementia is a major human, social, and economic burden. And I think it's very interesting and very nice that dementia is indeed getting a lot of political interest as well. And also it's interesting that actually both WHO and G8 Dementia Summit identified prevention as one of the key elements when we are trying to control this big epidemic. At the same time, it was clear, and I think it's getting more and more clear, that finding the drug development, the disease-modifying drugs, is maybe more challenging what we have been thinking. And here we really need some new way of thinking and more joint efforts between these different stakeholders. But my talk today will mainly focus on prevention, and the question here is indeed, what do we know about prevention? What can we do? When I started my research more than 15 years ago, this picture looked very different. At that time, it was not so much we could do. It was mainly high age and genetic factors that were the only, I would say, established risk factors behind dementia. And this created quite pessimistic picture about the possibilities to prevent Alzheimer's disease. But luckily, during the last 15 years, this picture has really changed a lot. And now we have evidence from several long-term epidemiological studies linking many modifiable risk and protective factors to dementia and Alzheimer's disease. And here we have, I would say, highest evidence concerning vascular risk factors, especially at midlife. But we have also several lifestyle-related risk factors, for example, unhealthy diet, diabetes, smoking, depression. And luckily, I think it sounds always more optimistic when we can also talk about protective factors, not only risk factors. And here, especially active lifestyle, including physical, cognitive, and social components, seems to be protective against dementia. So it's getting more and more clear that dementia and Alzheimer's disease are complex, multifactorial disorders. And one thing also is important what we have learned. Dementia has a long course. The first changes in the brain may start to develop as early as 20 to 30 years before we get the dementia diagnosis. And that means if we want to prevent dementia, we need to start early. I normally say it's never too early to start to prevent dementia. So probably here, latest at midlife, we should start to do the prevention work. We know that high age is the strongest risk factor for dementia, and that's why dementia is increasing so rapidly in the aging societies. However, it's interesting that we have now recent reports indicating that the age-specific prevalence rate or the incidence rate of dementia has been declining during the recent 10 to 15 years in several societies. We have reports from US, from Netherlands, from Sweden, and from UK showing the same picture. And these studies cannot, of course, give the final answer why this is happening, but it has been hypothesized that this is related with higher educational level, reduced incidence of stroke and vascular risk factors, and healthier lifestyle. And this gives to us indirect evidence that prevention of dementia is indeed possible. In the same way, it's possible to prevent many other chronic diseases like cardiovascular disease and stroke. And here I have a pleasure to present very new data from Canada. This is a study from Vladimir Hasinski and his colleagues. It's not yet published. It's actually in press in JAMA Neurology. And I got permission from Vladimir to present this data here, but he asked if you would be kind and not yet disseminate this outside this room, given that it's not yet published. As you can see here, it seems that Canada is also following this positive trend I showed in the previous picture. The incidence of stroke has been clearly declining during the last 12 years. And as you can see, the dementia seems to follow the same trend more clearly during the last 6 years. Again, pointing that it's important to have joint actions, and maybe we should talk about integrated interventions between these major chronic diseases. One question what remains is to what extent we can prevent Alzheimer's disease. Is it 10% or is it 60%? What do you think? Do you have any suggestions? 10? 30, 50, 10? There have been many different estimations. Of course, it's not possible to give the final answer. 50% has been the number that has been presented in many studies, but it has been criticized that that's maybe a little bit too high. And actually, one of the latest studies where they used a bit more conservative way of calculating, taking into account that many of these risk factors are interrelated, they are maybe not independent. This study pointed out that it would be around 30% of all Alzheimer's cases that are related, that are linked to these 7 major modifiable risk factors: diabetes, midlife hypertension, midlife obesity, physical inactivity, depression, smoking, and low education. And for me, 30% is a huge number. And if you have a little bit ideas for the future, what would happen if we would be able to reduce all these 7 risk factors 10% per decade until 2050? Then we would have 8% reduced amount of Alzheimer's patients. And if we would be so successful that we can reduce all these risk factors 20%, then we would have 15% less Alzheimer's patients. That would be 16 million cases. So it's huge numbers. And one more thing what I want to highlight here, we do not need always totally prevent Alzheimer's disease. Maybe even postponing or delaying the onset we know would have a huge impact. And I have started more to talk about risk reduction, not only prevention. That is maybe the more, I would say, realistic goal what we can say. So what has then been missing so far, I would say, is the evidence from randomized controlled trials. This has been really the challenge in the dementia field. We have had very many negative trials, unfortunately, and there are surely many methodological issues for this. Concerning prevention, maybe one of the most important one is that the previous studies have been quite short-term trials, and they have been using the single domain concept. They have been not taking into account this complex multifactorial etiology of Alzheimer's disease. Why we in Finland were quite quick to start this multi-domain intervention is really, I would say, we can be grateful for this extensive pre-finger framework what is available. And by this, I mean that we have had a long tradition in risk factor monitoring for cardiovascular diseases. We have had the FinRisk cohorts running since 1970, and we have been simply building on these existing cohorts and this knowledge. We have also had successful interventions for cardiovascular risk and diseases and diabetes. And what we have been doing during the last years is trying to integrate this multi-domain intervention to prevent cognitive impairment and dementia into this existing framework. Here is an example from the diabetes prevention study in Finland that is really a landmark study showing that it is possible to prevent diabetes, type 2 diabetes by lifestyle intervention. Here it was with dietary counseling and physical activity. And as you can see, diabetes was decreased by nearly 60% during 6 years. And this study and the others gave to us the rationale and inspiration to start the FINGER trial. We started 2009 when Academy of Finland had a specific call for public health challenges, and that time we got the core funding to initiate the FINGER trial. And this trial is coordinated by the National Institute for Health and Welfare in Helsinki in Finland, and is conducted between, I would say, all the major universities in Finland and also Karolinska Institute in Sweden. So it's really a joint collaboration between many stakeholders. And FINGER study is, I would call it, proof of concept trial to test how well this multi-domain approach that has been successful in cardiovascular disease prevention and diabetes, can it also fit for cognitive decline prevention. In the FINGER trial, we targeted at-risk segment of the general elderly population, so it's important to remember that these were not patients yet. And what did we do in the FINGER trial? This is a 2-year multi-domain lifestyle-based intervention having 4 main domains: nutritional guidance, physical activity, cognitive training and social activities, and monitoring and management of all metabolic and vascular risk factors. We recruited the patients again, or the participants from previous national surveys, the FinRisk surveys that I mentioned, and that gave to us a very unique baseline data set that is normally not available in these kind of trials. And totally, we had 1,260 persons. Age range was from 60 to 77, and they were randomized into 2 groups. One received this intensive lifestyle intervention, and the second one was the control group. And here you can see the different centers. We had 6 centers in Finland for the study. And we have had very exciting times with the FINGER trial now because we, as Howard mentioned, published the study just recently. And now we are also working with the extended follow-ups. We will do the follow-ups 5 years after the study and 7 years after the study. The target group, that is really one of the crucial questions in our trials. Who is the good target group for the trial? And as I mentioned in the FINGER, we wanted to have at-risk persons. We used the dementia risk score that we have earlier developed, including different risk factors for dementia. For example, high age, low education, high blood pressure, low physical activity, indicating that the participants had at least some modifiable risk factors present. And the second criteria was cognitive performance at mean level or slightly lower than expected for age. However, we took away persons who already had dementia or clear cognitive impairment. Here you can see again the multi-domain intensive intervention. So the intensive intervention group received nutritional guidance. We used both group sessions and individual sessions, and that was led by a nutritionist. For physical activity, we had aerobic, anaerobic, and balance training, and it was led by a physiotherapist at the beginning of the study. And as you can see, the training got more and more intensive during the time of the study. For cognitive training, we used computer-based training program that enabled individually adjusted difficulty level. And for the vascular risk factor control, we had visits with the nurse and doctor. How about then the control group? What can we do here? You can think because of the ethical reasons, we can't leave these persons without any advice. And actually, these persons got regular health advice, or they got even more. They came to us more than 10 times during this 2 years of intervention. So I would call it to be a mini intervention versus the intensive lifestyle intervention. Here you can see a picture from the finger intervention, and it was really a successful strategy, I would say, that we used the same groups. Persons did the training in the same group. And in that way, they got really the social aspect of the intervention as well, and also extra motivation. If there was someone who did not come to the gym, so the others called immediately for that person and asked where you are. So it really increased even the motivation to be part of the study. So really the experiences of the participants have been very positive, and they also liked a lot the fact that there was these individual counseling sessions. They got more individual tailored feedback at the same time. Outcomes then. The primary outcome in the finger study is a neuropsychological test battery, a total CHED score. This includes 14 different tests that are sensitive for early changes in Alzheimer's disease and vascular cognitive impairment. And as you can see, we have also a long list of secondary outcomes. Dementia and Alzheimer's disease, but here we need at least 7 years of follow-up. We have also factors and aspects like depression, disability, quality of life. And I think that is important because in that way we can understand what is the total benefit of this type of intervention. I believe that we can at the same time have many positive, many aspects that are positive even here. And as a researcher, we also want to understand what is happening in the body when we are doing these interventions. And that's why we are doing a lot of studies for blood markers, brain MRI, and PET as well. At the moment, we are just analyzing how the intervention is affecting telomere length. That's very exciting, I think. Results then. What do you think? Can we do some difference with this type of intensive intervention? To be honest, when we started the trial and when we did the analysis, I was still quite humble, mainly given that there have been so many negative trials in the field, but also because 2 years is still quite short time, and these were still quite healthy persons. But we were very happy to see that these 2 years intervention gave significant beneficial effects on the cognition. Here you can see the primary outcome, the NTP CHED score. And after 2 years, the red one here is the intervention and the blue one is the control group. After 2 years, both of the groups improved. And that's often what happens in these type of trials. But as you can see, the intervention group improved much more. The improvement was 25% higher, and that was statistically significant. We also did a pre-specified sub-analysis for the main cognitive domains and could see that there was even greater effect for executive function, where the improvement was 83% more in the intervention group. For processing speed, 150% more improvement, and for the more complex memory tasks, 40% higher improvement. We also wanted to check if there was a difference for cognitive decline during the 2 years, and there was indeed, so that the control group had around 30% increased risk for cognitive decline during the 2 years. It was also interesting to see that the intervention had quite long-lasting effects on the lifestyle factors. So that, for example, body mass index decreased more in the intervention group. Fish intake, daily intake of vegetables, physical activity was much higher still after 2 years in the intervention group. And as we know, this is always the challenge to really do the long-term changes in your lifestyle. We had just started to look a little bit the secondary outcomes, and this is just an example for the quality of life. And we were happy to see that even here we could see clearly that the intervention group was doing much better, especially in terms of health-related quality of life and components for general health, mental health, and physical function, indicating that this intervention has more broad effect. It's not only limited on these cognitive functions that I showed you. Side effects. That's of course one interesting issue. Are these type of intervention feasible? We were happy that there were no serious side effects at all. No difference in the myocardial infarctions or strokes. Now, I'm sorry that you probably can't see the numbers clearly. Something has happened. But as said, no serious adverse events. The only adverse events that was there was the slight musculoskeletal pain after the gym training that could be expected, and that disappeared if they had a short break in the training. I was a little bit worried for the component of stress, because this was quite intensive, this lifestyle intervention. But as you can see, only a few persons and quite equally in the intervention group and control group had some stress symptoms, and we do not know if they had anything to do with the trial. We also finally check a little bit the adherence. These are self-reported numbers, any participation, but they look quite good, meaning that nearly all of the persons or the participants could do at least something for these intervention components. The numbers are a little bit lower for the cognitive training, could be partly because we use the computer-based training, but still I would say that they are quite high. We were also interested to see if the participants were able to attend all these 4 components, how this multi-domain intervention works. And as you can see, even here, it was more than 70% who could participate in all these 4 different domains, really meaning that this multi-domain intervention may be feasible. Lastly, just a few words about future. And here I really would like to stress the importance of multinational studies and pragmatic prevention programs in the dementia field. Finger study is important, but it's of course not enough alone. And I'm very happy that in Europe we have also 2 other quite similar type of trials as finger, using the multi-domain intervention idea, pre-DIVA study in the Netherlands, and MAP trial in France. Both of these studies are also ready now. They have not yet reported, but they should report in any moment, I believe. And what we have been doing already is that we have building a data sharing platform, so that at the end of the trials, when all have been reporting, we can pull together all the data, and then we have more than 6,000 participants. And in that way, we hopefully can get even stronger evidence what type of intervention is working. We can do more subgroup analysis and so on. What we are also doing is we are trying to use the new technology to disseminate this multi-domain intervention even for wider groups of persons in a cost-effective way. And here we are just now working with the HATISH project, where we have been building interactive internet platform with easily available nurse support that can motivate and support lifestyle changes. One more example what we are doing at the moment is a MIND-AD trial supported by the GPND. And simply what we are doing here is we are taking the finger protocol and we try to adapt it to the memory clinics for patients who have already mild Alzheimer's disease. And I think that is very important because for this group of patients, we do not have any evidence-based guidelines in what way we should give guidance for these lifestyle interventions. And finally, I just want to stress that really these lifestyle interventions are extremely important at the moment because we do not have any disease-modifying drugs at the moment. Here you can see all ongoing clinical trials in Alzheimer's disease, different phases from the preclinical to phase 1, 2, 3, and 4. Different colors represent different targets. Everything that is in red has something to do with the beta amyloid. And as you can see, the red dots have been dominating the Alzheimer field and the drug trials during the recent years. Luckily now, I would say during the last years, there are more even other possible targets, tau, and even other possible mechanisms. Anyway, we know that there have been no new drugs for Alzheimer's disease for more than 10 years. We have had more than 200 drug development failures in the last 30 years. The failure rate has been higher compared to any other field. And in that way, it's obvious that we need to do something in a different way. And luckily, there are now these new initiatives where we try to start the treatment early. We try to find these new solutions. But this is, as said, in the future. To summarize my take-home points, for me the question is not anymore if we can prevent dementia, the question is more how we can prevent dementia. And first point here is the timing. As I mentioned, it's important to start early as possible, latest at midlife, and try to find these at-risk persons. Second point, we need to remember the complex multifactorial etiology of Alzheimer's disease, and indeed the multi-domain intervention seems to be the way to go. And here we have now the evidence from the finger trial, and I hope it can be a pragmatic model that can be tested and adapted in various settings and populations. And finally, for the future, I really believe we need to have even larger multinational studies. We need to develop pragmatic prevention programs. I believe we have enough evidence to justify some immediate actions already now when it comes to dementia prevention. And I also believe strongly that the integrated interventions between stroke and dementia field, for example, are important. At the end, I want to thank all my colleagues in these different institutes, and then I want to thank you. Thank you so much.
Thank you for this excellent presentation. It's a tough question, but do you have any insight as to what component of your intervention was most effective?
It's a very good question, and I do not have any answer yet, but we will try to analyze the data in that way that we can see if we can find the component that is strongest. If we go back to the epidemiological evidence, I would say that for all these components, the risk relation and how much they are increasing the risk is quite similar. So it more, I would say, depends how common are these risk factors. And when I show you the picture about how many, to what extent Alzheimer's disease can be prevented, the population attributable risk in Western countries is highest for physical inactivity. If you think globally, then low education and smoking are the strongest ones. So it depends, I think, on the population, what are the strongest risk factors. But I would guess that in many Western societies, physical inactivity is one of the strongest ones.
Thank you for your wonderful talk. I have a comment and a question. The comment is that I think an important missed opportunity for prevention of dementia is undiagnosed metabolic B12 deficiency. Most doctors do not understand that a serum B12 is total B12, of which only 6 to 20% is active. So within the normal range from 150 to 600 picomoles per liter are many people with metabolic B12 deficiency who could easily be treated. To be sure that someone does not have B12 deficiency, the serum B12 needs to be above 400. And that's only 26% of the patients in my stroke prevention clinic. And we found previously unidentified metabolic B12 deficiency in 30% of patients above age 71. B12 deficiency causes neuropathy, myelopathy, dementia, and increases the risk of stroke, which also increases the risk of dementia. So this is an important missed opportunity. My question is, why did you not mention smoking? Is it because smokers are underrepresented among the volunteers?
Yeah, it's a very good question. I mean, if I start with the smoking was part of our intervention as well as part of the healthy lifestyle counseling. So it was not like one of the 4 components, but it was there. So we gave feedback about that, and I agree smoking is an important factor. About B12, I agree there is surely more we can do there. We have been doing a lot of studies with that as well, and I agree that maybe the cutoffs we are using now we have been showing that even persons who have little bit low values can really have an increased risk. So in the finger trial, we did not recommend any vitamin supplement, but we more recommended a healthy diet. But of course, if some persons had low values, then we even could recommend the supplementation. But I think specifically for that type of study, we should do more research as well.
Thank you. So I've had a request that people might please identify themselves and where they're from when they ask a question so everyone can know. So we have a question over here. Okay, someone else has one.
I think I'm the next one. Okay. I'm Carolyn Gauthier from University of British Columbia. I work in cancer prevention, and I was struck by how much similarity there is between the things I say and what you say. And so my first quick question is, are you going to be tracking cancer outcomes in your long-term follow-up?
Yeah, it's very, very interesting question. And yes, we are. We are trying to track all different chronic diseases with the healthcare registers. In Finland, we have quite good registers, so that's possible to really do the linkage. So absolutely, then that's very interesting to see. Can we see something there as well?
Okay. And my question is, I guess I'd like to challenge you a little bit in your recommendation that we address interventions to at-risk populations, because as I look at your list of risk factors, and one of the biggest ones for both cancer and dementia is getting older, I mean, we all pretty well are at risk. And is it possibly a more economical and more wide-ranging approach to have population-based interventions rather than directing them to people at particular risk?
Yeah, it's a good question, and I agree. When we are aging, age is the strongest risk factor. We are all at risk. So in that way, you could give recommendations for the whole population. Then maybe you can have more targeted, more intensive interventions for those who really have additional risk factors. And especially, I'm also thinking that we know that not all persons are following our advice so well. There are issues with the socioeconomic factors. We are just now doing more analysis there. So you could have the more general approach for the whole population, and then targeted interventions to those groups who have more risk factors or who we know are more difficult to reach with the general advice.
Thank you.
Okay, we'll take one last question, and then we will have a panel at the end of the next session. Please go ahead.
I'm John Flores. I'm a cardiologist, and I was struck by the fact that you only had 7 on your list of population attributable risks, because over the last 30 years in my ambulatory practice, I've identified other conditions which have been associated with cognitive decline. One is obstructive sleep apnea, which appears in about 50% of cardiovascular patients and is occult in more than 2/3 of those patients. But if you have repetitive nocturnal hypoxemia that's not recognized over months or years, this could be an issue. A second is occult atrial fibrillation. A third is a severe orthostatic hypotension. And a fourth is a quite striking history of head injuries playing football during high school and university.
Yes.
Could you please comment on each of those 4 potential preventable conditions?
I totally agree. This list, what I showed with the 30% of Alzheimer's cases to be linked to that, was quite conservative. As I mentioned, the authors there had been focusing only on the factors what we really had a strong evidence. But I agree, head trauma, sleep apnea, we have increasing evidence that they are also there. And given that, I think that 30% still might be an underestimation if we put there all possible modifiable risk factors that might be there. And maybe in the future we could build risk scores really having even evidence from there. But absolutely, I agree. These are surely important as well.